Okay, we are going to begin the recording and start our meeting today for June 24th Behavioral Health Delivery Working Group. We appreciate your attendance and contribution to the work that this working group is doing, so thank you. First, we'd like to just acknowledge that we are recording this and we'll be posting the recording on our website for your access and review if you'd like to do that, as well as our other meeting minutes and materials that are presented within the meeting. My name is Jennifer Stroheker. I serve as the Director of the Division of Integrated Healthcare. I'm here with my colleagues to facilitate this discussion. We certainly appreciate your engagement and contributions to the work we're doing. If you would please, just as part of our complete meeting minutes, if you would please, if you are on the working group, would you put your name and your organization in the chat, just so that we're sure to capture all of our attendees today. So if you go ahead and do that, we can make sure that our meeting minutes are complete. And as you're doing that, we would like to just please move into the approval of our June 10th meeting minutes. So you should have all received a copy of these minutes. If you have not, let us know so we can make sure you have the ability to access these. But if we could just go through these, I'm not going to read through them today just for the sake of time and making sure we can move into our work, the work. But if you have a chance to just look through these, and if there are any changes, please bring them up. If not, I would love to take a motion to approve the minutes when you're ready.
This is Jed Burton. I'll move to approve the minutes.
Thank you, Jed. Do we have a second motion?
This is Russ. I'll second.
Thank you, Russ. Okay, all in favor?
Aye.
Thank you. Are there any opposed? Okay, thank you. Motion passes for approving our meeting minutes. So these will be posted as final on our meeting log and the meeting website. I did put together a couple of slides, and as we mentioned last meeting, we'll move into the formal agenda now with regard to operational concerns. We set the stage last time with the commitment to work through operational concerns as they're identified, brought up in this meeting. We want to make sure we have a forum for discussion and making sure we're working through any items that are an issue or a barrier to moving forward with our working group activities. So in the context of our last meeting, what we committed to do, first of all, was where there is an operational concern around claims payment, billing, eligibility, any of these issues, that if you are working on these and they're sort of one-off issues, we agreed to work on these offline. We invited you to first work with each other. If this is not doing, we would love for you to work with the Medicaid team, specifically Dave Wild, in reaching out and letting us know that you have these issues so we can facilitate. The sooner we know, the better. And we are committed to helping you reach resolution and us reach resolution with some of the issues that you're identifying and dealing with. The second piece of this is, while we are working through these issues that are more one-off, we said if there are more global issues, we certainly want to bring this to this setting and work them out here in a public forum so that we can work through the larger concerns. But in the context of these smaller concerns, we agreed to capture them and bring them back to this work group so that we could have visibility into them and show you what it is we've identified. And so for that purpose, I'm going to share my screen here for a moment as we move into this agenda item and actually just go through the issues that we've identified in the last couple of weeks, and then subsequently those that are resolved. And then there are a couple items that, of course, are newer or are ongoing. So item 1 and item 2 have been identified, brought to our attention. Dave within the behavioral health team has worked with the providers. And of course, we know that the provider groups have also worked together to identify and resolve these issues. So just to quickly note what we're finding, these are operational. Some of them are very operational in nature, and some of them, certainly item number 2, where we were identified of long-standing issues around billing for members that actually happened to not be Medicaid members. They were marketplace members. So we were able to identify and work through these issues. Other issues too, item number 1 had to do with some of our rate adjustments and working at billing the using the bundled code versus the more individual codes that we've looked at as well. So I don't know if there are any questions around these or if there's more detail that you'd like to bring up, but I wanted to just bring visibility to these and also note many of these are issues that we want that are very simple to, once identified, address and resolve with you. So we want to solve these. We want to work on them with you. Please loop us in to these discussions and don't let them go on and on and on, so that we can actually help you reach resolution with some of these challenges that you're facing with claims billing, claims adjudication, things like that you're seeing. I don't know, Dave, if there's anything else you want to add to this conversation, or if any of the providers or individuals on the call want to bring up these issues, but if so, we can do that now.
I don't have anything else. Just please include me when you have things so we know what's going on. Thank you.
Okay, and yes, we have a question from Horsepour. Sorry. Go ahead. Oh, I think you have no sound. I'm sorry, we can't hear you. Russ, let's move to you until we can figure out the sound. Try pushing *6 if you're muted on and you're feeding through your phone. *6 should unmute your phone, or the down below, of course, is the sound tab. But Russ, let's move over to you if you don't mind.
Okay, thank you. I hope you can hear me okay.
I can hear you, Russ.
The IOP bundle, will you just explain the issue with that? And these were closed codes? Is that correct?
Yeah. Dave, would you explain the detail on this and how you walked through this?
So currently for intensive outpatient and day treatment, we don't do a bundled code. We just have the plans bill individual codes. So there was issues mainly when TPL is involved, since they need to bill a bundle code to the TPL and then bill Medicaid, and then just other issues. It's a lot simpler to bill bundle code. So we'd be bundling these services into a payment for IOP and for day treatment. So it's not a new service, Russ. It's just a different, kind of like how we bundle residential, SUD, and mental health now. Same idea.
Okay, great. Thank you.
Okay, anyone else? Adam.
Yeah, I just wanted to make sure, my CFO had met with one of the plans, and I just wanted to make sure that the communication on the new rates is going well between state Medicaid and the ACOs for this year. One of the plans said that they don't know what the rates are, so I'm just wanting to get ahead of the issue because July 1st is, just around the corner.
Mm-hmm.
So
yeah, thanks, Adam, for bringing this up. So I believe at our meeting 2 weeks ago, I did have a slide with an email communication that did state that I'm not recalling the exact date, but sometime a few weeks ago, an email was sent to both the ACO plans as well as the behavioral health providers as well, with an update on the new rates. Specifically what the rates were and that they would be live in the system on July 1st. And so this was communicated several weeks ago at this point, 3 weeks ago. And if there are any providers who have not received that communication, please let us know. The other issue we've also identified, Adam, and I think this is a good point to bring up, is that we have had our ACO providers, the plans reaching out to some providers and have learned that it's gone to a spam inbox. So if we could just encourage also, I mean, I know it may not happen very often, but it still does happen that sometimes our communications have gone to spam. And this is an issue that was brought to our attention that the ACO had been emailing the provider, and it had been going to their spam inbox. And I think just to confirm also, Adam, that you also, all the PMHPs should have received this communication about our new rates for July. So that would be our residential treatment as well as the methadone rate increase. So if there are any providers or individuals on this call who did not receive that but should have, please let us know. You can put it in the chat or email me, and we're happy to communicate that. It would have come from Eric Grant, and I can look at the specific date for when that did. So any of the providers, PMHPs, Adam, if you didn't get that, we'll just confirm with you. We did send that out. So.
Jen, I can talk. Eric sent it out to all the ACO plan directors on May 27th. And then we also brought it up in every individual plan meeting. And then Eric also sent it to the PMHP directors on June 2nd. Adam, obviously not being in any of those groups, probably didn't get that.
Right.
Yeah, no, I'm well aware of it. I guess it's more out of a conversation that my CFO had with a plan that was unaware of the rate. So I just wanted to make sure that we're getting out in front of it. But if everybody else has it, that's great. So
Okay. Thanks,
thank
Adam.
you.
Thanks for bringing that up. Okay, I'm really sorry we can't address your question or comment without your audio unless you want to put it into the, I apologize for that. Okay, so if there aren't other questions, I apologize, I hopped through. The next few minutes of our call are meant to be pretty speedy, and I just wanted to frame our conversation as we move into the next piece of our conversation that really looks today. We've tried to approach our first few meetings with a very focused approach on the patient, the member, the client who is receiving care, to really understand our TAM member. And first column is looking at utilization data. From our Medicaid utilization data, what does this population look like? And this is meant to be a summary. We have much more, of course, but Brian was able to walk through a fair number of slides, as well as we had a piece of print material that we shared with you as well, that really helped you see from a utilization standpoint the needs of this population, what was being utilized. Last meeting, we were able to engage in greater discussion around sort of other needs, things we're not seeing that come through in utilization claim data, but we know that this TAM population is receiving and really is a necessary component of success in coordinating care and meeting the needs of this group. So I thought we'd take just a moment to recap these two pieces before we move into our third piece, which we touched on also at our last meeting around metrics of success. And so we could really understand these. And we're framing this for the purpose of understanding what the needs of this population are, so that we can create the best integrated benefit or integrated delivery system for them in the context of this. So first and foremost, as a recap of some of our utilization data, we know that outside of the public health emergency, this is a pretty small population. 5,000 individuals are enrolled in TAM. We have more today, but about 5,000 individuals are enrolled in this TAM benefit. 3/4 of the population comes from the justice involved category. Majority of these are male, and are between the ages of 30 to 44. Most live in our 5 urban counties. And we see this from the density graph around where individuals are receiving care. Now, over the span of enrollment, and so know that we're looking not at frequency of care, but with regard to what care they are accessing, about half of our members have received at least one visit of primary care, and 39% had an ER visit. We looked at medicines and had a conversation around that. Here's a summary. 31% of our membership received antidepressants, 21% antipsychotics, and 18% of them have received MAT. About half of our members have one chronic condition according to our claims data, and 1/3 of them have both a co-occurring physical and behavioral health condition. Okay, 20% of our members drive 74% of the costs for this population. So again, this is higher level. We have much more data in the documents that we have shared with you previously, but it's important for us to frame our conversation based off of the utilization data we have. We recognize that this does not tell our whole story. We know that sometimes access to care and engaging in care can be spotty. We know that we may not see exactly what the membership experience is with our utilization data, but we know that it's complex, it's high risk and high cost, right? And co-occurring conditions is something Brent's going to talk about a lot more today. We also know that this population also requires extensive coordination in order to achieve the health outcomes we're looking for. And we have some of these captured. These are taken really directly out of the dialogue we had last week in the meeting minutes. We can add many more to these. But some of the things you brought up in our meeting last week talked about the requirement of intensive case management and care coordination. Care coordination can be achieved through community health workers, social workers, different points across the community, and different both government funded and community based services that we use to facilitate care coordination in the community setting, and even to begin engagement in care as an individual is leaving the systems and moving in through risk assessments and working with jails. There were some great things brought up around one-stop medical visits, and how, because of the infrequent nature of members engaging in care, and sometimes the difficulty of making sure we're able to provide comprehensive care. And there were great ideas brought up around services that are being delivered today around one-stop visits, and also sort of community days where you run sort of patient-specific days that look at targeted event days. We looked at patient engagement and incentives around gift cards and food cards. That might be food cards, hotel stay waivers, so that we could help prepare people for, specifically bowel prep, so they could have a colonoscopy and do some of the preventive work that's needed around screening and things like that. So excellent, great ideas that were brought up. There was also this medication, and we're looking at medication adherence and the need for individuals. We know also 21% of individuals are receiving antipsychotics, many of them injectable antipsychotics, and the need to stay adherent to these, and strategies that have been put in place to achieve adherence and help members and help patients stay on their medicines. So this is not an exhaustive list. It was brought up in our meeting in the context of our work last week. Certainly would love to add to this as other things are voiced. But with this, we want to really transition today into a deep dive discussion around what it means to define success in this population. And before I transition over to Brent and the piece of the meeting he's going to run, I wanted to touch more specifically on a couple Medicaid specific items that were brought up in our last meeting And I just want to make sure they're part of our conversation before we move into this other piece. And the first is our waiver, our 1115 waiver that has been submitted to CMS, titled Medicaid Coverage for the Justice Involved Population. This was based on language that came out of House Bill 38 in the 2020 session. This was put into our 1115 waiver submitted to CMS of June of 2020. And what this looked at was getting Medicaid enrollment 30 days prior to an individual leaving the system and being able to have a smooth transition when leaving from the jail into and moving into the community to help have greater continuity and reduce interruptions in delivery of medical services and those services that are offered through the Medicaid benefit. And so with this, we wanted to bring this up as a highlight that this is still a priority to us. We are still talking to CMS about this and pressing them to work forward on this waiver. However, it has been put on hold by CMS because we're waiting on federal guidance. It's in a work group where they're trying to develop more of a comprehensive package of what this can look like. And as a result, our conversations around this waiver have been halted at this time. We are still engaging with CMS and letting them know we want this. We want to continue talking about it. But while they're working on their federal guidance, we're kind of waiting on CMS. So just so you know, that's where we are. We're waiting, we're asking, we're letting them know it's important to us, as many other states are, and they are working on it and will bring that back to us. The other item we wanted to just bring up in the context of this population was eligibility. So we know when an individual is enrolled in the TAM benefit and part of our TAM population, that they are automatically enrolled in 12-month continuous eligibility. Okay, so this is a benefit because it's not month to month. We're not requiring paperwork and that piece of eligibility review on a month-to-month basis. So automatically, when an individual is enrolled, they get 12-month continuous. But there are a couple caveats that we wanted to bring to your attention, that at the end of that 12-month time frame, if that member is still enrolled, they have another eligibility review with our DWS caseworker. If they are determined eligible for TAM at that time, then they stay on TAM for another 12 months, regardless of income changes. But if at the end of the 12-month review period, they have income that actually puts them over the TAM limit, they can become adult expansion eligible. If they are under the adult expansion limit, then they still may be eligible for the TAM benefit. So just so you know, there is this possibility that this individual could transition to a different Medicaid program, such as expansion, which offers potentially a different package or wraparound services than what we're seeing here and talking about with our TAM population. But it is possible they could stay enrolled with the TAM benefit as well, depending on income level and what that eligibility criteria is. So if there are specific questions around eligibility, we can certainly take those. But we did want to just put that out there as one of the factors we want you to be aware of and just to think about as we move into our other work around what this integrated benefit would look like. This eligibility in the context of eligibility is something we want to continue talking about as well. So we don't need to deep dive into it today, but wanted to bring it up as a portion of our conversation to just make you aware of what eligibility looks like for the individual who becomes TAM eligible, and make sure you're aware of the possibility of after 12 months, there is a possibility of transitioning out of the TAM benefit at that time as well. And also to be aware too, that the benefit we're looking at in the TAM population could look different than that benefit that could be received through the expansion delivery system as well, because it's a different service at this point. As we know, TAM is a fee-for-service population, and our expansion population may have a different benefit service delivery system than the TAM population receives. So with that, I don't know if there are other things others want to bring up. or talk about at this time? If not, we can transition over to the meat of our discussion today, which Brent will facilitate. Great. Thank you, everyone. Okay, Brent.
All right, can everyone hear me? Great. All right, this is the part of the meeting again that relies on your participation. And and these discussions have been really interesting to me. I've been involved in these discussions for a long time. It's also stimulated a lot of internal discussion within our office about what our next step should be. The agenda planning discussions have been interesting. The data that we're looking at is stimulating thought. And I hope that we can gather your best ideas as we go forward. So, why are we having this discussion? Well, House Bill 413 asked us to form this group to identify ways to improve the delivery of behavioral health services for our enrollees. And I think that we've provided data to you to demonstrate that the TAM population is not a population with just behavioral health concerns or just physical health concerns. This is a population that really has whole health needs and has issues in both areas and requires close coordination. Last month, we had a great conversation with you. And to recap that a little bit, you brought up a number of issues that you felt were necessary to improve. We talked about care coordination and case management, community health workers, and the role that they play in helping TAM members navigate this system. We also identified that people need help with access and sometimes help with enrollment. And I think that's important just to set the stage for the discussion we want to have today. In terms of the national data, I thought I would just present a little bit of information today about this population and what they bring to the table and what we see nationally. And I don't think it's going to be news to anybody on the call. People with physical health conditions such as asthma and diabetes often have higher rates of substance use disorders or mental illness. And I think that we can almost see that in the TAM data. 50% of Medicaid enrollees nationally have some type of mental health diagnosis. Persons diagnosed with mental illness and common chronic health conditions, their healthcare costs are much, much higher. And we see that across the table. The cost of diabetes treatment, for example, can be as much as 4 times higher if that person has depression or an untreated alcohol use disorder. And we've said this for years in our system and tried to make people aware of the fact that individuals with mental illness often die 25 years earlier than the general population. And substance use disorder is also, it results in increased mortality. And so, I think that, as we go forward with this group, I think it's important to recognize the whole health needs of this population. And what I'm new to this office, right? I've always approached Medicaid from a different seat within state government. And I can tell you, as we talk about it internally, we really want to focus on improving the health of the population within TAM. And that really is the goal of this. We recognize that in doing so, there'll probably be some cost savings too. But ultimately, I think that the goal that we've identified is improving the quality of care, improving the health of the population that's receiving TAM benefits. And so now to move into the meat of the discussion, what would that look like? What do you look at when you're evaluating your success with this population? Anybody want to lead out? This is the part that relies on you. Adam?
Sure. I can at least give a stab on what we do as an organization to evaluate success. So obviously, reduction of symptoms. So like abstinence from drugs and alcohol or reduced use. no new incarceration, job, healthcare complaints, wage earned. All of those things are things that we measure for success for our clients. I don't know if that's helped, but it's at least it's a first step, at least from a provider, what we look to whether we're successful with a patient or not, including length of stay and how engaged they are and all of that.
No, that's great, and that's very similar to the scorecards that we developed within the Division of Substance Abuse and Mental Health. Others from the physical health, what are the metrics that you evaluate to determine whether or not we're making improvements? Russ?
Yeah, I'll toss in a couple. One is, of course, follow-up after hospitalization. Are we able to get individuals engaged into follow-up care within 30 days and more ideally within 7 days upon discharge? And measuring readmissions, because that obviously, if you don't do the former with engagement after hospitalization, that you end up back in the hospital. Also looking at engagement rates in care management, and looking at data on who's high risk and high cost, and are we getting them into care management? And if we're not, then what population which group are we not getting in? And then are we engaging them through other means such as outreach workers? So there's just a few that come to mind.
And Russ, when you look at that, do you look at engagement with behavioral health care? Is that what you're looking at specifically?
It's engagement. So on the first two that I talked about, readmissions and follow-up after hospitalization, those are behavioral health specific, but there's similar physical health measures, particularly readmissions. On the care management engagement, that's their overall chronic needs. So and typically it includes everything. It's behavioral health, it's social care, and it's physical health.
Okay. My question, and that's helpful, thank you. My question for the behavioral health providers on the call, do you do any analysis or evaluation of a person's physical health needs? And what does that look like in your systems?
And Brent, this is Jed. I can speak up. We certainly evaluate that on intake for all of our clients, but we also, I think you're aware, have a primary care clinic embedded at Weaver Human Services. And I will say one of the tricky parts for us is identifying good outcomes on the physical health side in addition to behavioral health, because initially we wanted to decrease cost to the physical health system, but that's hard to show over a short period of time. It's really easier to show over a lengthy period of time. So initially, when we got people who hadn't been involved in physical health care or primary care for several years, initially the costs went up quite significantly because we were getting them treatment for illnesses that hadn't been treated for years. So yes, we certainly do look at physical health issues, and we're trying to come up with some short-term objectives or measures for those that we engage in physical health care. And I do like what Russ said, if they've been engaged with a community health worker or somebody that's on the physical health side, like a care coordinator or something.
Great. Adam, I know you also have a physical health clinic. What do you look at?
So I'd say very similar to what Jed was talking about, that we're looking at chronic diseases. So everybody who comes into any of our behavioral health program is getting a history and physical, and we can get a real good picture of what their disease, what their physical health looks like. And most often they have a number of chronic physical health conditions. So our view of success is one, either managing it through our primary care setting or connecting them to a specialist that then get them stabilized, and then return to our primary care setting to continue chronic care management over time, and really education about how to manage chronic diseases appropriately and preventative care appropriately.
No, that's great. And I'm, we didn't put the group together necessarily with that in mind, but I'm glad that the behavioral health providers are also thinking about physical health. Others, what are you looking at, Lisa?
I think one area that we've struggled to codify that is really significant are these pregnant moms, because it's not, of course, pregnancy is not a disease, but so it's coded a little differently. But you look at moms that are able to, we've struggled to find a way, how do you codify the outcome of having a child be born with fewer problems, because those are the really expensive births, but it doesn't fall in the disease category. So I've seen a lot of issues that we could better, if we could find a way to codify it, we could get a lot better data on savings that way.
Yeah, okay. No, and that's a metric that we've used in our system for a long time, related to successful, pregnancies or children born drug-free, but you're right. I've never really felt comfortable with the way that we do that. So we could probably use some assistance from the physical health side in terms of evaluating outcomes. Any thoughts, Dr. Whittle or others?
Yeah, I completely agree, and that's a very important population to focus on. So getting that right would be fantastic. I'm just wondering how from this group, how much deployment do you think we have in terms of putting physical health care into behavioral health? I've loved the projects, and I think they're incredibly important. I wonder how much opportunity still exists there.
Build on that a little bit, Dr. Whittle. Last time you talked a little bit about this, but why don't you expand?
Yeah, so and I think it fits exactly what Lisa and Adam are talking about, and Russ as well. If I were to take a wild guess, I would say we're probably about 10% deployed in terms of meeting medical needs in behavioral healthcare settings. That there's a lot of opportunity still there for doing good. Community health workers play that connection piece, and I think they'll be an important element of that strategy. And I hate to push to solutions, but if you look at that CCBHC model, a lot of the pieces of that are the coordinating elements that help connect these parts of our healthcare system together. And so I just wonder if we as a group agree that there's a lot of opportunity for deployment, and if we need additional support around those connecting elements to really make those, to really deploy the way we would like to.
So do people understand what Dr. Whittle's talking about with the CCBH model? What would be the recommendation, Dr. Whittle, about going forward with this group to explore that a little more?
Well, I appreciate the question, Brent. I don't know if I'm the person to make a recommendation, but I'll tell you from my perspective, as a provider and as somebody who wants to support behavioral healthcare providers, what I love about the CCBHC model is that it creates a strategy within Medicaid that provides for funding for providers who commit to a series of quality-related services that address the very issue we're talking about today. And when you see a strategy that's both fairly broadly adopted around the country, is very reasonably priced, and puts the funding right on the elements that we're kind of addressing today, it seems like a strategy that comes with a couple of benefits to it. Well adopted, has a funding strategy associated, and puts that funding right in the kinds of services that help us accomplish what we're looking to accomplish with blending these types of services together. But I tell you, it makes me a little anxious with this very talented group to go too far out on a limb. I'd love to hear what other people are thinking about that framework.
Well, let's open it up. I know some of you have looked at that. I've had discussions with others about CCBH. Thoughts, comments, other models? Lisa?
I just had a question for Emma with the core set of the quality measures that she just said. I just wondered, are we currently automatically tracking those?
So, Lisa, not all of them. Some of them are part of the current HEDIS measures, but ultimately what CMS will require, and I think it's beginning in 2024, that states will have to start reporting on all of the adult and child core set measures. So we're going to have to move in that direction.
Gotcha.
And I think one of the exciting things about this integration, one of the exciting things that we're going through as we come over to the Division of Integrated Healthcare, is looking at our evaluation schemes and maybe reducing some of the burden on behavioral health providers and looking more at claims data and HEDIS measures and things like that, so that we can eliminate some of the burden that's been placed on clinicians. And I'm excited about those opportunities to sort of align our data strategies and our evaluation strategies. I think that's an area where we can certainly improve. Trying to get back on track. So one of the things that we were tasked with doing is, looking at metrics, establishing goals. Do people agree? Is there consensus that really what we want to do going forward is focus on population health or better serving this population? It was interesting. Dr. Whittle said last time that, TAM is a fee-for-service program. And one of the major reasons was we were concerned about access. And I think so it made sense to go with kind of a fee-for-service opportunity. And then as we brought this group together and we talked to you about the needs of this population, I mean, if you look at the meeting notes, pretty much everyone here said we need better care coordination, better case management, help navigating the system, getting people to where they need to be. And you would kind of expect those kinds of problems in a fee-for-service arena, right? So we can solve for those problems. But I think that's really where we are in the evolution of this is how do we solve for those problems? And there are some exciting things happening. One, how many of you are familiar with sort of the collaborative care model? And so, our office will be releasing some grant opportunities for collaborative care, which is an evidence-based strategy for integrating physical and behavioral health services. And it can be implemented, within primary care or in other settings, actually. And it includes care coordination and case management, regular proactive monitoring and treatment. And it's been studied in many different places all over the country. I think there's 70 different studies now that show positive outcomes from provider groups that are using this model. What else are you seeing? What other changes would you recommend to us related to TAM? Is collaborative care the right way? Is CCBH the right way? Let's have that discussion.
Brent, I'm wondering if people don't even know all the various models that are out there. We've been in a managed care state for a while, and so asking them. I think if we could present, I mean, there's lots of different options. I don't think people even know exist.
I would agree, and I guess the question is, how do we want to proceed going forward? Do you want us to dive into one during our next meeting? Do we want to, bring in some experts on CCBH on these calls and have that discussion as a group and explore it? help me with some recommendations to keep this conversation moving in a positive direction.
Yeah, and real quick, Brent. Oh yeah, go ahead, Joel, because I know you had your hand up for a little bit here. And then Brent, could I just direct you to a comment in the chat as well, just to add some things that were made. Go ahead, Joel, if you want to speak.
Okay, I was just going to kind of double down on what Brent said. And yeah, I think it's a good idea to invite some experts in, especially from some states that are a little more, a little further along on Medicaid reimbursement. So we are in the transition of kind of bringing 3 different Medicaids together. Not in this conversation, we're talking about 2, but as CAM is enveloped by the ACOs, they're now dealing with one that has a 12-month eligibility, and then the expansion that doesn't. Aligning networks is another issue, so that people churning in and out of eligibility of Medicaid because of income maintain that continuum of care. And I think that's a topic I'd like to have for this group, just because it seems like it fits so well. And then after that, I'll wait until I have more questions.
Okay, thanks, Joel. Adam, you have your hand up.
Yeah, so I think having some information on different payment models will be helpful. I think as we're talking about this discussion, that we're not bringing a solution in search of a problem. Like, are we seeing real gaps in this population? Are we broken? So making sure that we're not breaking something that isn't broken already. And the second part is, I think if we're going to really, if the value in folding this into managed care and managed care in general is to provide potential additional flexibility, I think that really needs to be the discussion, is that we need to treat this population, not just behavioral health, not just physical health, but all the other social determinants that go into their long-term success. And so I think if we really want to have a robust discussion, we really need to start talking about it as a chronic care disease and starting to pay for it like that. So like episodes of care and long-term models of, acute treatment, but then the maintenance phase being all part of what we're going for, at least on the behavioral health side. So I want to make sure that we come out of this better than we went in, and I really do think we end up paying for these services in potentially the wrong way, and I really do think we should be treating it as a chronic disease and in episodes rather than days. So.
No, that's helpful. Do you know of areas where we do this within healthcare, or in other areas, or do you have some specific recommendations you'd like to bring?
A great example, and I think Scott would be really great to answer this. But if you look at physical health and DRGs, so if a woman is pregnant and gives birth, the hospitals paid a DRG for that, and potentially if there's a complexity to it, they get an enhanced payment for that. But that is pretty common on the physical health side. Like, you are paid X dollar for this diagnosis, and have varying levels of complexity that adds onto it. And I really think, that works well. It incentivizes both the provider and the payer to have skin in the game and have positive outcomes, and there's shared savings on both.
Yeah, thank you. I think that's a fantastic idea. You know what, the behavioral health side, there have been several national models moving towards that type of strategy with behavioral health. You take the DRG model and you expand it a little bit to fit more the chronic model instead of episodic, like surgical model. That's the most common application of DRG is procedure. And then it just moves into the space where you're talking case rate, and you put a time frame to it. You look at the clinical complexity in terms of medical, social determinant, and behavioral health. And then you put a case rate around that and hand it to somebody, a network of providers or a provider that has a continuum of care that's robust enough to meet what would be anticipated in that course of care. And you provide a case rate for it and economize a great deal of administrative dollar and a great deal of flexibility. We've made big efforts to make that happen with, you know, an amount of success. I think there's a lot of people pointed that direction, both nationally and locally. I think it's a great idea.
And that does that generally happen within a managed care construct?
Yeah, it's most comfortable in a managed care construct because it's something that managed care tends to be very familiar with. You know, so it leans into the value-based care contracting world that we've all been encouraged to sort of try and flesh out. So yeah, I think so.
Yeah, and so, you know, it's, I mean, one of the things that was sort of, and I mentioned this briefly, one of the things that was interesting to me is that, you know, the problems that we sort of identified during our last meeting about what this population needs and gaps are the problems that I would expect to see within a fee-for-service system, right? And I guess I just want to say, with this population, is that still the right payment structure, or is that why we're having problems? Let me put that out there.
Brent, on that, I mean, 413 is talking about giving TAM an integrated benefit. They currently have an integrated benefit through fee-for-service, which also gives them the most access. The piece,
Right.
as you noted, is the care management piece. There are managed care models that just cover the case management piece. That is the
Right.
piece that the managed care plan would be providing. And then there's some value-based payments through that as the care management shows some benefit to cost and to outcomes for the members, then they end up having some benefit to that plan as well. So it's a win-win across the board. So that way you still have fee for service, you still have access, but then you also have a robust care management program in place as well.
That's
Yeah, I totally agree. And let me just add one other concern out there, because the fee-for-service model has the coordination challenges you're bringing up, but it doesn't have the access problems, or it shouldn't. And yet we continue to have access problems across the board, except for in the areas where I think providers have really stood up and created a lot of access in the most critical areas. So I think you have plenty of access if you're at the higher acuity levels up into that high residential, because there was a lot of very thoughtful effort at making sure people weren't left without care at those levels. But if you go looking for care below the 3.0 level for individuals with these services, it starts to get thinner. And when you get to the 1.0 level, it's incredibly hard. And the 1.0 level is where we really create the solutions we're looking for. And so, this is one of my hopes, is that when we start talking about the COC model, the collaboration of care model, which I think is absolutely essential, the CCBH model is, I think, very harmonious with the COC model. Both of them fit together very well. And so, I think those really are pointed at the solving that 1.0 level of care and trying to keep care at that level where appropriate, so that it's that body. I apologize, I'm like a broken record with this, but when you look at the body of the bell curve, it's the body that we're having a hard time with, not when people get into real trouble or when people are healthy. It's what do we do when people are medically ill and mild to moderately in trouble with something in the social determinant behavioral health SUD side. That 1.0 level just isn't the safety net we need it to be. And I think those two models we're talking about do probably the best job that I've seen in terms of addressing that problem. So I just wanted to make sure access is a problem I don't see a short-term solution for unless some of these structural changes are made. And even then.
No, okay. Yeah. It's funny that the more we discuss, the more I realize I need to learn. And so it's helpful to have this group here, kind of walking through this. So in terms of next steps, it's interesting. I mean, I guess as we look at metrics for this population, one of my recommendations is that we capture both physical health and behavioral health concerns, and that providers from both arenas essentially understand that we're trying to better coordinate care. The behavioral health providers understand that they have a responsibility to coordinate with physical health providers. Physical health care providers understand the responsibility to coordinate with behavioral health, and that we look at engagement and retention and making sure that the person's getting the care they need overall. And we look at that as success. Is anyone concerned about that direction? I mean, that to me seems like a no-brainer. Okay.
And I think, I think the one piece is, how do we capture that? So we all agree with that. And I think a critical piece, we'd love to hear from you today, and we did touch on it. So I don't think we skipped right over it. But what are those metrics? How do we capture that? And certainly, I think the bill does touch on some pieces. Emma produced and Russ, you touched on these HEDIS measures, right? What are the other metrics? What are they? If we look at all the players in the room, whether it's the provider, the payer, and definitely the member, how do we capture our metrics of success around these three areas? And I do think I want to make sure we're thoughtful in this, because as we evaluate models that are out there, and there are numerous ones, right? And certainly we can come back next meeting and look at these various models and the benefits and things that could exist in them. How do we ensure we understand the patient? We know this. We've taken our time to look at this. And then we look at the needs and how we're capturing success through the model that we move towards, right? But what are those metrics, and what do we have? What are the tools, resources? What are you using today to capture that? Is it claims data? Is it, patient survey? What are those? Is it timely payment of all the payers, right? To make sure that's a piece. We opened our meeting talking about that, right? So what are those? Because they all matter in being successful. So sorry, Brent, to deviate back.
No, and that's helpful. And what's interesting to me, and what my next statement was going to be, is that to me, and I grew up on the substance use disorder side of the division, the most important metrics are about initiation, engagement, and retention in care for individuals with substance use disorder. As we gathered information, those were the most telling things that we really had. It's not the best. It's not I wish there was more, but those were the elements that I think were the most highly correlated with positive outcome. And I think that HEDIS and most of the national quality metric development consultants would agree in substance use disorder, which is very similar to what we were saying on the physical healthcare side. So I think we could do a better job of gathering that within the Division of Integrated Healthcare, and I think it would be meaningful information. And I think in mental health, that's probably pretty consistent too. If you have someone that's diagnosed with major depression, initiation, engagement, and retention in care are probably pretty good starts. And that's data that we already have or could be developing through Medicaid for this population. But I don't think that we've emphasized it enough I haven't been looking at it enough, right? In terms of these specific Medicaid programs and what that looks like. But what else? Don't want to just share my opinion.
Brent, this is Russ. Not to go backwards, but I'll kind of build on what Jen was saying. So a couple things that people brought up that I think might be helpful going forward. One is Emma brought up the core set, and it might be good for us to look at that. It's been a while since I've looked at the core set from Medicaid of measures that has been developed versus NCQA HEDIS, and they were working on alignment there, but not complete. I don't think it was complete alignment, but it may be at this point. I think that would be worth looking at. I also think, though, that the piece Adam brought up about, moving towards a value-based system, and I know, Jen, this is a priority for the state as well. And, I think success looks like over time growth in value-based care. And capturing that is important, and categorizing it to understand in which ways are we, or how are we moving? Is it pay for performance type of value-based care, aligning incentives to get the right outcomes? Is it, moving towards bundled payments that allow, as Adam described it, that episodic care to be, and all the incentives to be aligned for a provider to be able to deliver all the right care under a bundle payment versus an a la carte fee-for-service type of choice? And are there broader incentives being developed for a system to engage the system? I just think value-based care is probably a piece on success that, that as Adam brought up, his comments really made, and the example of DRGs in global deliveries on the physical health side, there's so much room for us to grow in this space that we should count that as success, but document, are we moving in the right direction?
Okay, thank you. Dr. Whittle?
Yeah, I couldn't agree more. I think that's really pointing in the right direction. It feels like, and we've dug into this a number of times over the last decade or so. And what we tend to find is the metrics that are handed to us by CMS and CMS associated organizations can they go from fairly general into pretty into the weeds on some pretty detailed stuff. Because of our access problems, we've really had trouble dealing with the core issues in those measures. And so you end up looking at, 7-day access, post-hospitalization, post-emergency department admission, 30-day access to treatment, post, 7-day, 30-day post. We're looking at things like readmission rates, and all of those things are fantastic. They're still very general, but quite honestly, one of the core reasons I think we've struggled to make traction is because of access. Because you can have a very well-intentioned system, but if it doesn't have those pieces that reinforce with a broader base of human resource, connecting those elements, then it's really hard to make traction. And so I think these comments really get to that issue. Because if we do create a value-based care arrangement, then the low dollar solutions for creating those connected pieces, which are frankly not licensed individuals, which are one of our major challenges, is the human resource shortage we're experiencing. Sure. But these connecting pieces are just not in that area. So that's right where that lives. That's right where that problem lives.
Adam?
Yeah, I just wanted to address some of what Jen, the metric stuff, because I think the discussion we're having is kind of maybe the method to get there, but I think we need to remember what matters to our patients, and really to the legislature and to the taxpayer is, are they out of jail? Are they out of prison? Are they out of the criminal justice system? Are they stably housed? Do they have a job? Are they taxpayers? Are their symptoms reduced? Are they happier? Have we reunified a child with their mother? Like those are the things that matter. Readmission rates, sure, that is a cost event, but really, if we want to know whether we're doing a good job, those are the things that matter. And so I'd hate to lose sight of that.
Agreed.
Yeah, and I'm hoping that as we align, those are the things that Medicaid can learn from us. Hopefully, we can learn to collect that information in a way that's less onerous. but that because I think those measures of productivity or recovery or engagement, just a life in the community, I think are really important, because I think that's the ultimate outcome, that you can be retained in care in a lousy system and not be getting any better. And so I do agree with you. I'm hoping that we can kind of sort that out and build an evaluation strategy that brings the best of both of those worlds together. So that's helpful. Joel, you had a comment? I think you're on, are you on mute?
No, that's better. Yeah, I think I just wanted to touch on that, what you mentioned, Brent, and I think we talked about this before, maybe a year ago or so, but when it comes to metrics and ensuring providers are tracking them, tying that tracking to metrics to the reimbursement mechanism may yield better results. So if you make it part of the reimbursement structure that you have to track X, Y, and Z, then and even on the CCBHC front, then maybe you're one of those more high aligned providers. Reimbursements get better, and all that stuff. But until providers are almost required to collect that data, they'll be collecting their own, which shows, a 90% success rate.
Okay. Let me say one more, as I was looking to prepare for this meeting, I was looking at the SAMHSA information related to integrated care. I was looking at the collaborative care model for another assignment. And I came across this statement and I wanted to throw it out there and get your response. And we've talked a little bit about this, and I think payment strategy is important. But basically, what SAMHSA identified is that traditional fee-for-service reimbursement programs have been a barrier to widespread implementation of collaborative care. Do you agree or disagree?
Agree.
Okay. And so, I think that that's one of the problems we have to solve for. And I think it can be solved in many different ways. And I'm certainly not smart enough to do that on my own. But I think the discussion we've had is pretty helpful. And at least this group's in agreement that we need to be evaluating, the health of the person and all of their needs, not just the needs that we've been assigned to serve. So that's helpful. What SAMHSA is saying is, and I think we're having some of this discussion, but they also talk about capitation, case rate payments, Adam. I think that's what you're talking about, or pay for performance mechanisms being sort of the solution to that. And so we're kind of headed in the same direction, right? Is that what I hear people saying?
Mm-hmm.
So how do we get there?
Would it help to have someone come in, an expert in these pay for performance scenarios, maybe the next meeting, take 10-15 minutes and then answer questions in a system from another state that's working kind of the way that we're working too?
Could be. What I'd love to do is talk with Jen, talk with Nate, and think about our next steps. But I think that it is, if we're really interested in integrated care, we either have to solve for the problems that the current structure creates, or we need to think about some different ways of doing this. Is that a fair statement?
Yeah.
And I think the problem that we're seeing is that if an individual walks through the behavioral health door, we're concerned that their physical health needs are probably still being underdiagnosed, and in many settings, not all, and vice versa. If someone comes through the physical health door, sometimes there's difficulty connecting to behavioral health, and so making sure that we solve for that problem. And there's a lot of work being done here. My favorite group is the Center for Excellence from the National Council on Integrated Health. And I think that they've provided excellent training and guidance to us in years past. And so that's another one that I would throw out, Joel, is a great source for information about how to do this administratively, clinically, et cetera. I think that they've provided some excellent resources. Lisa?
Just when I hear some pretty wide parameters, and I know one thing that would help me and a lot of other people on here as well, just like you mentioned with the Center for Excellence, if there are things that we could that you would recommend that we look at away from here, so that everybody's up to speed and we don't have to spend too much meeting time explaining some of these basic principles. I think that would be a training opportunity that almost anybody here would be willing to do outside of here, get us all up to speed on some of the things you mentioned.
Yeah, no, I think that's great. And I just put a link in the chat to a brief on the collaborative care model that I found this week that I thought was excellent. And it goes through that. And I'm not pushing or endorsing that model necessarily, but I was just trying to, prepping for these conversations for me is really tough because I know that I'm, with a super group and I better be prepared. So I'm not going to pretend to be the expert, but I am trying to prepare. So
that's a great resource. And just so that Scott Whittle doesn't seem so much smarter than the rest of us, it helps us improve our general intelligence as a group.
Yeah. So I do actually, I like where we got today, right? And I think that, and let me try and summarize, and then if people respond, I think in terms of how we would define success, we would look at metrics from both physical health and behavioral health. We talked about initiation, engagement, and retention really in both systems being important. We also talked about the need to look at additional metrics related to recovery, productivity, life in the community, and trying to put those together. And then we started to talk about some payment models or some changes in strategy that may work to deliver more integrated care or to increase the amount of care coordination to identify or solve for the problems that we identified last week. And then there was a request made for this group for additional information about some of these models and maybe having some expertise brought in to discuss with us some of the things related maybe to CCBH, maybe to integrated care or collaborative care. So is that a fair summary of where we got today? Okay, Jen, if I hit all of my bullets?
Yeah, we've covered more than your bullets. So thank you, Brent, and everyone else for the robust discussion today. So I do feel that there is a lot thrown around in our conversation, and I know I was trying to keep to a pretty quick pace through my section, but I want to be thoughtful about that piece around measurement and what we look at with regard to success measures, quality, that type of thing. And so I don't want to jump too quickly through that piece because it's complicated, and some of the models and the payment pathways that were introduced today, maybe beyond the scope of what is possible in the time frame we have, right? Because these are large, different things than what we have in place today. So I also, want to put in perspective that, Medicaid and CMS and those things too are in the context and certainly central to the where we want to be in another year, right? With a July date in front of us. So with that, I would love to kind of capture our notes and put them in a summary so that we could just look at them collectively. Even our second piece around sort of these wraparound services and these other additional services, I feel like we need more contribution in that area, because if we don't put it out there, I don't want to miss it. Like this is an essential piece to success for this group, yet it wasn't on this, brief list that I showed today. And so I do want to spend a little bit of time engaging in that and also bringing back these other pieces that were discussed today around how we look at value and how we look at success measures. And I love that we talk about, HEDIS measures and things, but it really does come back to what matters to the patient too, you know, and what matters to them in their life and what is success to them. So we want to engage in those pieces too, and not just jump through those to get to our sort of the end. So I'd like to spend a bit of time at our next meeting just mulling that over. And so if you could do that and bring back your thoughts as well for discussion, or just adding to that, I'd like to do that and maybe not rush too quickly through those pieces.
Jen, one thought, and I'm thinking off the seat of my pants in front of my boss, so that's a little scary. But what if we we have a model for developing our scorecard, right? We could probably do that just for the TAM clients and compare it to other populations. We could also maybe look at initiation, engagement, and retention in terms of HEDIS, what we have currently for this population, and compare it to some of the other models, and put that in front of this group. And then we can once we can take a look at it and say, well, is this really what we need, or is there more? Is that a fair? Anyway, we can talk about it later.
Yeah.
Right? So,
No,
And
go ahead, Joel.
I sent an email out a couple hours ago too, outlining just a couple things kind of from the provider perspective, trying to take into account all the changes, the merge, everything. Any one of those is just a guideline or an idea. So feel free to throw those into the agenda how you'd like, but those are things that can kind of consistently come up on the provider side.
Thanks, Joel.
Yeah.
Okay. All right. Well, we've got about 10 minutes left. That's our traditional Q&A time. This is I appreciate this group's willingness to participate, and for those of you who didn't speak, I haven't gone through all the chat yet, but I hope that you're using that strategy to communicate with us. We're really going to rely on you to help us move this someplace positive. We certainly don't want to make the system worse, and I take Adam's challenge seriously. I know that sometimes we put this group together and we end up going backwards, so we want to avoid that at all costs. Do you have suggestions or recommendations to us about next steps to keep us on track and in line with the work that we're supposed to be doing?
Brent, has the 30% increase, those two residential codes been codified in rule? Have they come out with the rates? You know what I'm referring to?
We talked about that early, Joel. I think maybe before you were on the call.
Okay.
And we talked about that in the last meeting also, I think. So I think those changes have been implemented.
They'll go live on July 1st, Joel.
Yeah.
So those will be implemented July 1st. They did not go through the rulemaking process. We generally don't put our rate increases or rate changes through rule, but they are in our policy and have been distributed to behavioral health providers, PMHPs, ACOs. I'm sorry, not BH providers, but they were shared in the very early parts of this chat. If you can see, those were noted there, and they have been shared with the provider communities.
Right.
And then the ACOs are under the understanding that those are the rates. There isn't a difference in published rates versus a lookup tool or anything like that. Because there was a disparity before, which is why we ended up getting those retroactive payments, and they all made good on those payments, and we're very grateful for that. But I just want to make sure there's no speed bumps on implementing that when the ACOs were to take over.
Okay.
I guess that all depends on the payment strategy, but
yeah. Agreed. Hey, and I just wanted to throw out that collaboration of care model we're looking at. There's a reason we're mostly not familiar with it. It primarily lives on the medical side, and so those of us in this group aren't going to have a ton of contact with it. So just a small bit of background on that to maybe help us kind of point us in the right direction on that. Both Intermountain and the university programs have committed deeply to the COC program, over a decade of commitment to it. The deployment has been relatively small because of the complexity of standing it up, and there is a human resource challenge there. But there are very clearly experts in the space in the community that we can connect to who are still very motivated and I believe, justifiably motivated to get that program stood up, because it is a big piece of the solution, I believe. And so, that's something I've been neck deep in for over 10 years. So any support or help you want connecting to any element of what's been done in the state on that area, very happy to play that role and to help get anybody up to speed who would like to be.
Dr. Whittle, and I have so as I look at this, and I've been involved in these discussions for a long time, and bringing it into thinking about it in terms of TAM is sometimes kind of difficult, because I really believe that integrated care for individuals with substance use disorder is a wonderful thing. And it will help solve the access problems we have if the entire healthcare system is focused and addressed on these issues, right? And I think the same thing is true for mental illness. But when you read this brief that I put out, one of the things that it says very clearly is that, there's a population, and it's about 20%, that need specialty care, which most of the providers on this call represent, right?
Exactly right.
And they are essentially specialty care in this model.
Yeah.
And I think about TAM, and I'm like, that's kind of the population.
A lot of it. Agreed.
We haven't defined TAM in clinical terms as that 20%, but in many ways, they're pretty consistent. And so I think we have to keep that in mind too, is that, integrated care certainly has a role and is the solution for a large part of the population. But we got to get that right. We can't put the wrong population in that model.
Thank you. You're exactly right. In fact, that model as a whole is defined as moderate to mild. And so largely for TAM, it wouldn't be appropriate at all. But I think that goes back to what you brought up in the very beginning and others brought up at the beginning, was the reverse integration strategy of taking medical and pushing it into behavioral health, because that's the medical home for most of the folks that receive TAM type services. So I think if you combine those two ideas, you really start to develop a powerful strategy. So excellent point, Brent.
Yeah. Okay. Well, I appreciate the kudos. We're just about at time. Jen, do you have any thoughts or comments?
Nothing more for me. Thank you, everyone.
Okay. Well, we'll give you back 6 minutes of your day if we're ready to do that. Okay.
Right on.
Well, thank you,
you.
everyone.
Thank you.
All right.